So with that out of the way, I think we will go ahead with our public comment period. I will turn the meeting over to Sydney to introduce this portion of the meeting.
Hello, everyone. I would like to introduce our Zoom coordinator, Angela Driver. She will start the public comment period.
Good afternoon. Our first commentator is Andrew Wang. Thank you.
Hi, thank you so much for having me. My name is Andrew Wang, and thank you for this opportunity to speak to you today on November 14th during HICPAC's public comment session. My remarks today have been formally submitted as public comments. I have no financial conflicts of interest or fiduciary investments in companies or organizations that produce or manufacture personal protective equipment. First, I want to recognize and express my sincere appreciation for all of your time and meaningful work by this committee to provide guidance on the practice of infection control and strategies to ensure safe U.S. healthcare settings for our patients and coworkers. Balancing approaches is important when considering realistic, idealistic, or practical approaches, but the public trusts all of us in the medical community to understand and be aware of the evidence and adopt policies that ultimately enforce approaches that align with the evidence. During this meeting, the incoming administration has already announced an individual who has worked to discourage vaccinations and will be nominated as the Secretary of Health and Human Services. Establishing the highest standards is needed to protect healthcare and prevent individuals like this who opposes any levels of safe standards and will try to dismantle them. As a public health professional with a doctorate and master's of public health, I'm aware of the challenges in healthcare and the need for precise and meaningful guidelines. My expertise has been in the area of health disparities as a health service researcher focused on health equity. I serve at a federally qualified healthcare center that provides care for underserved and vulnerable populations in Chicago. And I was previously an administrator of an occupational medicine department in one of the largest academic medical centers in Philadelphia. Today, I'm speaking on behalf of the public who have ongoing serious concerns regarding infectious diseases such as COVID that spread in the air and currently affects the health and well-being of healthcare workers and patients in healthcare settings. Your decisions being made today establish a serious precedent for future generations, especially if these standards are not at the highest and most rigorous levels. Lowering these standards will result in putting healthcare workers and patients in more dangerous conditions and lead to a fewer allocation of resources for future pandemics, especially at less resource healthcare facilities that serve the most vulnerable and underserved communities like my own. Ultimately, higher standards ensure that the health equity is addressed, while allowing lower standards further worsen disparities. HICPAC has that important role to ensure the most rigorous and higher standards of protection regarding infection control guidelines because it impacts the health of healthcare workers and patients. The implications of today and tomorrow's decisions are far-reaching, including primary and specialty community clinics across the country. The isolation, precaution guideline, and healthcare personal guidelines are a pivotal decision point, especially with the incoming new administration. Already, persons of color and people with lower income or who face poverty have disproportionately worse outcomes in healthcare, but also from COVID infections and most likely will develop on COVID. I humbly urge you to strengthen CDC's infection control guidelines in line with practices that ensure the highest level of protections against the spread of an infectious disease, especially through aerosol transmission. First, I ask members of HICPAC to ensure the highest standards and to prevent and ensure the least number of hospital-acquired COVID infections and adopt an approach that protects against the spread of any diseases. Thank you so much for your time, and I appreciate all of your support in this work.
Thank you, Andrew. We appreciate your comment. Next commenter.
Our next commentator is Mary Germanis.
Hello, my name is Dr. Mary Germanis Sava, and today I'm here speaking on behalf of the People's CDC, a CDC watchdog group and health equity group. At the People's CDC, we continue to receive comments from our constituents complaining about healthcare facilities violating their rights to safe healthcare. These fall into two categories: healthcare workers who refuse to mask with patients, or facilities who refuse to guarantee N95 mask wearing or other reasonable accommodations. We have constituents who complain to us about themselves or other loved ones catching COVID at the doctor because practitioners refuse to mask. We are seeing again, in writing again and again from them, our constituents, that healthcare systems explicitly do not consider N95 mask wearing a reasonable accommodation, even if the patient has to be unmasked. We have many complaints about hospitals refusing people's requests to be in private post-operative rooms, even when these patients, again, are unable to be masked themselves, saying that this is too burdensome on the hospital. Although up until just last year, hospitals tested patients for COVID upon entry to minimize spread. Now, HICPAC is proposing to allow healthcare workers to return to work when they are fever-free, even though many people never have a fever at all with COVID, but they are still infectious. The CDC's own data shows that infectiousness varies widely. Ending isolation should depend on an appropriate isolation period of at least 7 to 10 days and 2 negative consecutive rapid tests, as attested to by our isolation letter signed by 400 public health experts. Not on the whims of employers who need to solve an ever-increasing healthcare employment crisis, exacerbated by untenable working conditions and the increasing crisis of long COVID. Now, your draft guidance is implying that healthcare facilities can determine whether or not workers are allowed to wear N95s in the workplace. We've already heard complaints about this at workers from Mass General Brigham, who made the difficult decision to quit their jobs because they were only allowed to wear surgical masks once universal masking was lifted in May 2023. Again, lifting universal masking was not a decision based on science. Listen to the public comments. Listen to your own scientists at CDC who continue to publish MMWRs showing how dangerous COVID continues to be. Just this September, a new MMWR showed that infants made a higher percentage of hospital COVID admissions than any other age group except over 75. Infants. In the study, nearly 1 in 20 required mechanical ventilation and 9 infants died during their COVID-associated hospitalizations. Children just at the start of their lives. Healthcare workers and patients will be drastically impacted by your recommendations. The public is overwhelmingly asking you to make universal masking the new standard of care and to require healthcare workers to wear N95s in cases of confirmed or suspected aerosol transmission, as well as to make N95 masks widely available within healthcare systems. Regulate and fund improved ventilation and follow the data on isolation protocols, not hospital profit margins. Thank you.
Thank you, Mary, for your comment. Our next commentator.
Hello, my name is Jackson Riso, and 3 years ago, I became debilitated by long COVID. I had to shut down my small business that I had worked extremely hard to build and let go of my 2 full-time employees. Each time I have gotten COVID, my disability has gone from bad to worse. We now have studies that demonstrate what I have personally experienced. Every time we get COVID, we get worse. Because of this vulnerability, it is not safe for me to access healthcare of any kind. There is no preventative care that is worth the risk of another COVID infection. Today, we have a greater knowledge than ever before of how viruses are spread and how damaging even seemingly mild infections can be. This knowledge was paid for in blood by the lives lost during the public health emergency. Yet we consistently fail to implement this knowledge, and so Americans continue to die in overwhelming numbers from hospital-acquired infections. Millions of vulnerable patients like myself, patients with chronic conditions like long COVID or cancer or heart disease, wish to receive care but don't, because we are all too aware of the crippling power that SARS-CoV-2 still has. Throughout the day, I have listened to your presentations. I have heard your talking points. I have seen your slides. I have looked at your charts and graphs, and I have read your bullet points. As a patient, I can tell you that you are missing the most fundamental question. Can everyone in the United States access healthcare safely? Yes or no? If the answer is no, then something needs to change. The recommendations presented in this meeting do not meet the demands of the moment. They will not make healthcare safe enough to genuinely protect the most vulnerable members of our society. It is beyond time to once again implement mandatory masking in all healthcare facilities. You are on this committee for a reason. What do you want your legacy to be? Do you want to be remembered as the ones who halted progress and said fewer deaths are good enough? Or do you want to be remembered as the ones who pushed forward and championed a new age of safer and more inclusive healthcare? The doctors who look to you for guidance swore an oath to do no harm. Today, we the patients ask you to lead them in fulfilling that oath. Masks work, we know they work, and it is time to make them the standard. Thank you.
Thank you, Jackson. Our next commentator.
Deborah Sokolar.
Hello, my name is Deborah Sokolar. I am active on pandemic issues with several public health groups. I am, for example, health policy advisor to Mask Together America, but today I speak only for myself. I'm a long COVID patient, cancer survivor, and retired health policy. I have a vocal cord disability, so will also submit my comments in writing. I'm aghast at the current continued failure to prevent healthcare spread of airborne germs that cause long-term disability and death. My mother caught COVID from a caregiver in 2021 and died of it. I caught it from her and still suffer the effects. Like many people I know, I can't risk repeat infection and worse disability. So I go without much needed medical care because healthcare settings pose a threat. Most have abandoned routine tests. Staff often work while infected, yet few staff mask. If I ask medical staff to mask, they often resist. HICPAC and CDC should call for restoring routine testing and masking year-round by all staff, visitors, and patients, except the rare patients who cannot, with widespread N95 use. I greatly appreciate panelists today who recognize that appalling numbers of patients and staff get COVID in healthcare settings, that facilities often don't know when surges start, that facilities may not know who is infected or high risk, and that action is urgent to strengthen ventilation, sick pay, and protections besides PPE. But few of your members have recognized those points. And it's disturbing to hear proposals to focus protections on high-risk units. High-risk patients use all parts of a hospital. Immunocompromised people shouldn't be endangered in the orthopedist office. And I worry, especially for my relatives whose babies are due next summer. A CDC webpage on protecting infants and children notes infants under 6 months have high COVID hospitalization rates, but offers no help except vaccination in pregnancy. How should hospitals and doctors protect newborns from widespread COVID? The need for universal masking is obvious, and routine testing of staff who shouldn't work unless infection-free. Sadly, your proposed policies won't protect infants or the rest of us in our contacts with healthcare. Thank you.
Thank you for your comment, Deborah. Our next commenter.
Shay O'Neill. Sorry, mic wasn't on.
Hi, can you hear me?
Yes, we can hear you.
Hi, I'm Shay O'Neill, advocate for patient rights and human rights in the COVID-conscious community, volunteer at the World Health Network and Air Support Project nonprofit, immunocompromised and apparently not in the picture and likely to be voted to be denied safe healthcare and thrown to the wayside, the way that things are looking so far at least. I have a few questions for you too, after I'm listening in on today and getting a small amount of time to glimpse the slides and now be given the grand opportunity of leaving a 5 or 3 minute comment to defend my life before you're voting tomorrow, which I'm not even sure is with the legal number of entities. First of all, who's going to send the memo to all the firefighters that they should start using surgical masks for wildfire smoke now? Oh, and to the lab workers that work with other infectious diseases like tuberculosis, bird flu, or whatever else pops up that can spread by the air, just let them know to put down those PAPRs and N95s, throw on a baggy blue surgical mask because it probably works just as fine. Who's going to tell NIOSH they were wrong in wasting their time on tests that certify these respirators protect from the particle size that infectious diseases like COVID spread on? And just let them know that surgicals are probably just as good according to a few cited studies that don't agree on outcomes. So you decided to ignore the more controlled ones and favoring the ones full of inconsistencies, and then use that to lead to the decision that abandons the entire field of physics and goes against current industry guidelines, because it's just a once in every 5-year infection control standard, after all, for healthcare facilities, where people who are at their most vulnerable inside of, during a time when SARS-CoV-2 is recognized to spread year-round and cause long COVID in 25% of infections, with reinfections looking worse. But maybe your healthcare workers aren't the ones spreading it to them, and it's just their visitors, because you all are magical. And oh, no, we couldn't ask the visitors to wear respirator masks. That's rude. These people in the hospital just need to deal with being repeatedly infected when seeking healthcare in their vulnerable position. It's a risk you all are willing to take today, and somehow you've been put in this position to decide for us. That's not the precautionary principle. The only way to address the reality of this breath-emitted, aerosol spread, short and far distance traveling, infectiously lingering, extremely contagious, quickly evolving, vaccine and immunity evading, year-round pathogen of COVID-19, and its often during long-term severe counterpart, long COVID, is to make aerosol filtering, face-conforming respirator masks like N95, their equivalents or better, standard precaution in healthcare facilities. Anything less will not work. And don't worry, you don't have to stay up all night to rewrite what you just did today. I'm pretty sure the World Health Network sent you the correct answers to CDC's 4 questions. It's in your inbox. And I'm pretty sure they're okay with you using them verbatim. Thank you for your time.
Thank you for your time, Shay. Our next commenter.
Caitlin Sunling.
My name is Caitlin Sunling. I am an MD PhD physician scientist and pathologist in Wisconsin. I have no conflicts to disclose. I'm a volunteer with the People CDC and Wisconsin Community Health Action, although I am not speaking on behalf of any group. I am commenting in support of universal masking and strengthening infection control policies. Infection control begins with the basic assumption that infections are worth preventing. Healthcare workers need strong guidelines from the CDC to ensure best practices are followed. I hope we can all agree that it should not be up to individual healthcare workers to decide whether hand washing is needed, whether exam rooms should be clean, or whether gloves should be worn during procedures. Masking is no different. This committee needs to decide, is aerosol transmission a personal belief or a scientific fact? All healthcare settings pose risks of aerosol-transmitted infectious diseases such as tuberculosis, COVID, seasonal influenza, avian influenza, measles, and so on. Many healthcare settings have implemented fall to winter universal masking without adverse impacts to operations. COVID spreads year-round, and year-round universal masking as a standard precaution is the only sensible solution to prevent healthcare-acquired infections. Masking should not only be a reactive approach that comes after preventable exposures have already occurred. Mask bans have been enacted in multiple locations, creating a dangerous situation in our communities. Meanwhile, healthcare crisis standards enacted during PPE shortages risk becoming permanent policies. This committee must formally address the very real instances where healthcare workers and patients have not been allowed to wear respirators, and where healthcare policies have been used to deny patient requests for staff to wear respirators. As the foremost authority on infection control, you have the opportunity to combat stigma and misinformation about masking by recognizing the need for universal masking in healthcare, and that respirators, at minimum N95, are the only appropriate respiratory protection against aerosol-transmitted pathogens. Regarding the healthcare personnel guidelines, shortening COVID isolation for health, May 2024, as Mary mentioned, the People CDC submitted a letter to the CDC with over 400 expert signatures supporting that COVID-positive workers must isolate at home for at least 7 to 10 days and should test negative before returning in person. Universal masking in healthcare with broad use of N95 respirators is necessary for safe patient care and workforce protection. Please use your authority to strengthen infection control using a multi-layered precautionary approach. Thank you.
Thank you for your comment, Caitlin. Our next commenter.
Dawn Ford.
Don, are you on the line?
Oh, hi, can you hear me now?
I can hear you.
Perfect. Hello, my name is Don Ford, and I have no conflicts of interest. I spoke at last year's meeting on this issue and am primarily focused on helping rewrite our vaccine policy with VRPAC and ACIP. Before I get started, I want to point out that the people on this committee who are able to limit transmission and create safe healthcare spaces are using a layered approach. And yet I hear other members of the committee locking onto individual aspects of their approach as if that single mitigation is enough alone. When you consider that it's not an individual item protecting folks, then you have to remember that splitting hairs over symptoms is completely pointless, especially when a large portion of transmission is asymptomatic. Rather than chopping up complex guidelines that can easily be misunderstood, this demonstrates they should be at least masking all the time and using respirators when they're concerned about symptoms or having had exposure. This debate has ignored the obvious solution of different quality masks for different environments. And if folks are symptomatic, then they should be home until they are not symptomatic. 3 or 5 days does not handle the issue. I hear the committee discussing what is best for hospital management when your role is to determine what is best for healthcare practices. The group is not called Hospital Management Practices, it's Healthcare Infection Control Practices Advisory Committee. You're supposed to be speaking to what is best for the patients and the healthcare workers providing care, and the hospitals are supposed to then fit into those regulations. We are not supposed to fit patients into the demands of the hospitals, or why even have this committee in the first place? And the work group discussion about endorsing voluntary masking missed that these rules are already being used against workers to prevent masking. You're putting undue requirements on the facilities and the workers. This confusion alone shows that it's too complicated not to have a flat recommendation. The current recommendation already lowers the level of care available. This has led to misinformation coming from healthcare providers themselves that masks do not protect them enough or that they don't need to wear them. At least the policy of any mask is better than no mask needs to be recommended by this committee if you're not going to have a full-time recommendation, though respirators should be required for any suspected pathogen that travels through the air in line with who changes to airborne. We dealt with this in the RNA vaccine recommendations this year, and a year later, we're unwinding that rule to what the right answer was the whole time with a recommendation for at least 2 boosters a year instead of 1. But unlike VRPAC, this committee does not meet over the same issues year after year, except this exact issue, because it got kicked back by the CDC for not doing what was best for administering care, and now you are making the same mistakes today. I need everyone on the committee to remember that we are going to be back here next year under a Trump presidency, still trying to make this work, because the same people who are commenting right now are the same people who got this issue kicked back in the first place. So you have to make it very clear right now. Also, when discussing 3 versus 5 days, many of you included incubation as part of the 2 days, which is not the right time for them to be in isolation. If you're so concerned about workers being out sick, then put masks on them all the time and upgrade the masks for different levels of exposure, then making respirators available to all staff. Work with NIOSH to create ease of use, our new standards, and from there create work groups to handle these other mitigations like UVC, air filtration, and other sterilizing methods. This will be added to the HAC list, and you should get ahead of it now. Thank you.
Thank you, Don, for your comment. We can move on to our next commenter.
James Morris.
Hello?
We can hear you.
Thank you. I will start by saying that I do have a potential conflict to share. I have worked at multiple pharmaceutical companies in the past, but my comments are entirely my own and are not connected to any company or organization I am a member of or have worked with. My background within pharmaceutical industry, where we are regulated by the FDA, has a significantly different approach to what is being done here and in healthcare facilities. The severity of the regulations and the consequences of failure to follow them in the pharmaceutical industry are so severe that it's common practice for pharmaceutical companies to go above and beyond the regulations to be absolutely certain there are no compliance issues, nor are there any problems that could even be suspected of such. The fact that you are even discussing many of the topics that are here today are things that are beyond the scope of even imagination or consideration within the pharmaceutical industry. And because of that, it is quite frankly a difficult, if not impossible thing to imagine even changing the minds of many of the people on this committee, because the ability to take a proper perspective on care seems to be beyond even the point of consideration. And because of that, I have little hope that this committee will change their way to take a more conservative approach to what should be done, as has already been mentioned by the previous commentators. The main point is more needs to be done than currently is to minimize and reduce and mitigate infections. It's not being done. There's a rush at most healthcare facilities to do the absolute minimum. Whatever guidance there is, that is the actual target that's done. And so the failure to even have a substandard recommendation is a failure of this committee. Thank you.
Thank you, James, for your comment. We can move on to our next commenter.
Deborah Gold.
Hello. Thank you for the opportunity to comment at this meeting. Can you hear me?
We can hear you. We can hear you, Deborah. I think you've muted yourself. We'll wait for a second.
Okay. Can you hear me now?
I can hear you.
Okay, thank you. Thank you for the opportunity to comment. I had retired from Cal OSHA's Deputy Chief for Health in 2014, but was recruited back to provide technical help in March of 2020 when COVID-19 was beginning to blaze through healthcare, congregate living, and prisons. The incorrect information that COVID-19 would not spread through the air and the lack of appropriate precautions allowed COVID-19 to overwhelm long-term care facilities and prisons. I again left Cal OSHA last year, and I'm not speaking for the agency. At least 13 people died during the first outbreak at San Quentin Prison, which started at the end of May 2020. 122 people were transferred in a 10-hour bus ride from the California Institute for Men, where 500 people were sick and 9 had died. On arrival, the men were placed on the upper floors of the 5-tier Badger building. 1,457 people incarcerated at San Quentin were infected in a 2-week period. The judge's tentative ruling said, Broomfield testified that he believed Badger was an appropriate and safe place to quarantine the CIM transferees because he believed COVID-19 could only spread through droplets or contact from hard surfaces, not through aerosolization. Staff were generally not using respirators and served as a vector for COVID-19 to different areas of the prison. Many employees were infected and at least one died. The Marin County Public Health Officer was concerned the prison outbreak had spread to the community. Ultimately, the state health department set up an emergency operations center to institute controls such as source control testing, physical isolation, air filtration, and respirator use. This illustrates the importance of the differences between scenarios outlined in the workgroup presentation. Scenario A captures what happened in May in San Quentin, which followed their past practices with diseases such as mumps and chickenpox. The built environment encouraged transmission of COVID-19. Simple masks were initially provided, and respirators, when provided, were not used consistently or correctly. Scenario B recognizes the importance of preventing both short and long-range inhalation and reflects what the CDPH implemented at San Quentin to stop the outbreak. Screening, source-controlled ventilation, and other engineering controls must be used to limit the areas in which infectious aerosols may be present and reduce their concentration. Where infectious aerosols may be present, employees must effectively use NIOSH-approved respirators, including respirators more protective than N95s. Clinical studies of infectious pathogens, laboratory studies, and 100 years of respirator use in various industries have found repeatedly that only respirators that fit the face will prevent inhalation of aerosols, including infectious aerosols. Where healthcare workers have additional personal risks, such as pregnancy or immune-compromised housemates, even when policy does not require respirator use, the employer should provide employees and allow them to use fit-tested respirators. Thank you.
Thank you, Deborah. We can move on to our next commenter.
Chloe Humbert.
Hello.
We hear you, Chloe.
Hi, I'm Chloe Humbert. Semmelweis is known for his campaign for hand-washing standards. He was attacked by contrarians until his death. Today is vindicated, yet respiratory hygiene is the science denier flavor of the day. It's not okay that doctors and nurses are maskless, breathing directly on patients who then get infected. Now is the chance for those in positions to do so to set a precedent for deserved protection of worker and patient safety, to be on record, giving evidence-based practitioners something to hang on to. We are going back. The only question is, how far back people and medical leadership are willing to sign on to. The announced incoming Department of Defense Secretary is someone who said on national TV that he doesn't wash his hands. We know what can happen because of what has happened before. In the 1850s, Florence Nightingale went to the Crimean War, a hospital in Constantinople. That's in Istanbul now. And that situation was no Turkish delight on a moonlit night. She arrived at a British military base atop a cesspool where patients lay in their own feces among rodents, and more soldiers died from infectious diseases than injuries in battle. Under Nightingale, the place was scrubbed, and she reduced the facility's death rate by 2/3. We might go further back. The Dark Ages was called that because society moved backwards from the technological advances that had come before. The fall of the Roman Empire was marked by elites who cared only about the status quo. They could have developed a steam engine as far back as Heron in 15 BC, but didn't bother. Going forward is a choice. In an article in the Journal of Infectious Diseases and Preventative Medicine, there's a description of what happened back then. Quote, "In medieval times, hospitals were hazardous places. Epidemic infections killed large numbers of hospital patients during this period. Hospital infection and death rates were high. When a sick person entered a hospital, his or her property was disposed of, and in some regions, a requiem mass was held, as if he or she had already died." Unquote. Going backward is a choice. We know better now. We use surgical gloves, autoclaves, disinfectants, checklists, and yes, respirator masks exist. But big healthcare corporations don't want to pay for that. They lock up PPE, force nurses to work without sick leave at hospitals, and make patients beg for reasonable accommodation. Going forward is a choice. Let this not be a case of rearranging deck chairs on the Titanic, but a time when serious healthcare professional leadership takes a stand for sanitary conditions in healthcare and makes respirator masks and the precautionary principle the standard of care, instead of doing with masks what would be like calculating whether you should wash your hands after the toilet based on age or health status. Thank you.
Thank you, Chloe, for your comment. We can move on to our next commentator.
Amanda Finley.
Thank you very much for the opportunity to speak today. My name is Amanda Finley, and I lead COVID-19 Long Haulers Discussion Group. I have lived with long COVID since March 6, 2020, and I'm here today to beg you to stop adding to our ranks and mandate universal masking in healthcare. At the beginning of the pandemic, I followed the CDC's every recommendation. We had no other sources to rely on, so we relied on the experts. Over time, it became apparent that what we were seeing on the ground was not being reflected in guidance. And over time, I lost all faith in the CDC. I also lost my home when I was too sick to work and wound up living in a tent. I got sick with COVID again before vaccines were available, and yet again 1 month after the pandemic was declared over and after receiving every booster. The vaccine-only approach has failed us in life-altering and lethal ways. Many are losing everything: partners, jobs. When someone in my long COVID cohort goes quiet and doesn't respond to messages or calls, I start checking obituaries, where I often find them. Some have even ended their own lives because existence is medically too unbearable. Yet when we go in to see our litany of medical experts, we do so at great peril. Almost none of them protect us by wearing something as simple as a good mask. We're even mocked by staff for taking precautions. The science is clear. 1, masks work. 2, the only prevention for long COVID is not to get COVID. And 3, vaccines, while a necessary tool of public health, do not prevent COVID. We clean water before we drink it. We cook food to eliminate the risk of most pathogens. We wash our hands to prevent fomite spread. Why are we not doing the same with the air we breathe when the risks are so evident? How many people have suffered needlessly because they put off care knowing their providers would not mask? In December 2023, Renee Seamarge of Kansas City, also a COVID long hauler, went to a pulmonology appointment masked, where she again contracted COVID. None of the office were masked. She has been primarily bedbound since. As we stare down the barrel of an H5N1 pandemic and an impending administrative change, it is imperative that we learn the lessons of COVID. We must protect our most vulnerable, protect the people who care for the most vulnerable, protect people from becoming the most vulnerable. We demand masks in healthcare. We demand proper examples to follow, and we demand true leadership. Please step up and fulfill the public mandate in your very name, the Centers for Disease Control and Prevention. Thank you.
Thank you, Amanda, for your comment. We can move on to our next commenter.
Peg Seminario.
Hello? Can you hear me?
We can hear you.
Thank you. My name is Peg Seminario. I'm an industrial hygienist and served for 30 years as the Safety and Health Director at the AFL-CIO until my retirement. I've worked on many infectious disease regulations and guidelines for healthcare workers, including bloodborne pathogens, TB, and COVID-19. Unfortunately, for decades, we had to fight CDC and many infectious disease professionals in the healthcare industry to recognize TB, SARS-CoV-2, and other respiratory diseases as aerosol transmitted diseases that required engineering controls, ventilation, NIOSH-approved respirators to protect workers. Now, given the experience we've had with COVID pandemic and all the evidence we now have on aerosol transmission, there should be no disagreement that existing infection control guidelines and policies are inadequate to protect patients and healthcare workers from infectious pathogens that pose an inhalation hazard, and that these measures need to be strengthened. But even with COVID, many now claim the pandemic is over and protections are no longer needed. But as you've heard today, the serious health risks continue. Nursing home workers and residents are getting sick. Individuals suffering with long COVID are getting additional infections, which make them sicker, and that millions of people have health conditions that put them at high risk. So the weak and inadequate protections in healthcare settings are causing many people to get very sick. And I can speak to you from my own personal experience. And I'm somebody who knows about COVID and knows about protection. I got a really bad case of COVID this past February. It was my first infection, despite being extremely careful about getting exposed. I'm at high risk, and my husband has very severe lung disease and is at very high risk. And the only place I spend any time indoors are at doctor's offices, in the grocery store, and I always wear an N95 or KN95. A few days before I got sick, I had a doctor's appointment at a large, crowded healthcare facility. I wore my KN95 except for the time I was in triage room getting my vitals checked. There was no mandatory masking policy at the healthcare facility, even though flu levels and COVID wastewater levels were very high, and none of the nurses were masked. A couple of days later, I started having symptoms. I tested positive. I isolated and took Paxlovid, but I was sick for over a month and tested positive for the same time. Even worse, I infected my husband, who now got very, very sick, which greatly worsened severe lung condition. And he also developed pulmonary embolisms that I've yet to resolve. He continues to have other effects. Patients and healthcare workers need stronger infection control guidelines and protections that require N95 respirator source control and voluntary use for inhalation hazards, not a continuation of the weak measures that are only making people sick. Thank you.
Thank you for your comment, Peg. We can move on to our next commenter.
Yanir Baryam.
Hi, can you hear me?
I can hear you.
Great, thank you. My name is Yanir Baryam. I'm the president of the New England Complex Systems Institute and co-founder of the World Health Network. I'm here not to address HICPAC directly, but to speak to those listening healthcare professionals, patients, and advocates who are committed to public health and safety. Let me highlight several critical concerns. Members of HICPAC and the organizations they represent have significant financial conflicts of interest. This issue documented in a complaint submitted to the HHS Office of Inspector General raises serious questions about the integrity of their guidance. Additionally, HICPAC has operated in secrecy, with workgroup meetings closed to public scrutiny. This violates the Federal Advisory Committee Act, which mandates transparency. Such closed-door decisions erode trust and undermine accountability. HICPAC also lacks the legally required number of voting members, further undermining the legitimacy of its recommendations and decision-making process. Most importantly, the science of airborne transmission, essential for understanding diseases like COVID-19 and tuberculosis, is glaringly absent from HICPAC's guidance. Ignoring this science compromises the safety of both patients and healthcare workers. Compounding this issue, the voting members of HICPAC lack the necessary expertise in airborne transmission. While they may consider themselves infection control experts, their opinions on this critical topic cannot be treated as expert input. Science must drive policy. It provides the evidence necessary for informed decisions about safety and prevention. When science is sidelined, lives are put at risk. One actionable step is for CMS to add COVID-19 and other airborne infections to the list of healthcare-acquired infections for which treatment is not reimbursed. This would align with existing policies and create a powerful incentive for hospitals to implement necessary precautions. Far too many have suffered illness acquired in healthcare, become disabled with long COVID, or died from preventable infections. Far too many have avoided necessary care due to these risks. Every preventable case is a tragedy and a failure of the system. Please call the HHS Office of Inspector General and ask them to investigate our complaint against the HHS Secretary, CDC Director, and HICPAC designated federal officer for gross misconduct regarding HICPAC's violation of the law. The Inspector General's office is very receptive. The direct phone number is 2.
Thank you, Yanir. You are at time. We can move, and thank you for your comment. We can move on to our next commenter.
Paul Hennessy.
Hi, no conflict of interest. HICPAC has woefully failed the public with your draft recommendations, which must be redone, and the vote needs to be delayed. Your precautions for airborne illnesses are especially antiquated, so let's start there. Your updated infection control guidance must follow the precautionary principle. You need to consult with aerosol experts and mandate clean air protections in hospitals, such as ASHRAE 241 standards or better, as recommended by the EPA. Your updated guidance must include isolation, low pressure rooms, frequent testing for COVID and H5N1, improving ventilation and air purification, and broad masking requirements. You discussed exceptions and who should be masking at what times and justifying your reasons to gamble on infectious periods. But it's easy. Everyone should be required to wear high-quality respirators. Staff, patients, and visitors. Also, COVID is infectious for 10 days or more. Not 3, not 5. Your return to work policies for COVID and flu are dangerous and force healthcare workers back to work while still infectious. This guidance must make clear obligations for employer protections, not exceptions based on profit margins. Worried about pushback from healthcare facilities? Elastomeric respirators are reusable, more economical, and even more protective than N95s. These need to be required for all pathogens, and it's malpractice to do anything less. COVID, TB, and H5N1 can all transmit asymptomatically, and without strict infection control measures, you are allowing illness to spread to vulnerable people seeking medical care. You need to go above and beyond for infection control in medical settings. That includes outpatient care centers. Why are you talking about when an employee should be allowed to sneeze without a mask? You sound like doctors in the 50s who recommended smoking. COVID vaccines have limits. They do little to prevent transmission, and repeat infections lead to immune damage and brain damage. Prevention must be paramount in medical settings for the good of patients and staff. The new guidance must also recognize the science on airborne transmission. COVID lingers in the air like smoke, and no amount of hand washing or surface cleaning will stop that. Masking and clean air need to be a part of healthcare in the same way that gloves are. Would you want to share a room with a COVID patient or see a maskless doctor who's just been treating COVID patients? The CDC must also redo its flawed evidence review comparing N95s to surgical masks. The two are not the same, and baggy blues do little to prevent airborne spread. HICPAC has failed to engage with the public or listen to past comments or provide transparency. Your email comment system makes it impossible to see the public record. Going forward, Comment periods must be available on regulations.gov so the public's comments can be accessible and we can hold you accountable for ignoring us. For the next 4 years, the Trump administration will promote anti-science rhetoric, the further minimizing of COVID and H5N1, less funding, and fewer protections for the medically vulnerable. But you all have ushered that in by stubbornly denying the science of airborne transmission and failing to improve upon prevention measures. It's time to put better airborne protections in place now, mandate masks across the board, and prepare medical settings for the best possible infections control measures. Until then, redo the draft and delay the vote. Thank you.
Thank you, Paul. We appreciate your comment. The next commenter.
Esther Harima.
Can you hear me?
I can hear you.
My name is Esther Hirama. I am the Executive Director and Administrator of a nursing home and senior living organization. But more importantly, I'm a family member of a nursing home resident. I'm speaking today on behalf of the 101 nursing home residents I have the privilege to care for, as well as for the thousands I have cared for in the past 30 years, along with their families and the staff who provide that care. On behalf of these individuals, I bring a request to decrease the isolation requirement for nursing home residents who test positive for COVID from the current requirement of 10 days to 5 days. Why? First of all, nursing homes are their homes. They live here. This is not a hospital where they go for a couple of days. Second, this outdated requirement forces caregivers to choose between doing what is required by a CDC directive last updated almost 3 years ago when COVID was drastically different, and doing what is ethically and morally right for our residents. A nursing home room is required to be at least 8 by 10 feet, which is 80 square feet. How would we all feel about being involuntarily secluded for 10 days in 80 square feet when we're not sick? Inappropriate isolation causes physical decline, including the loss of strength, functioning, and mobility. It causes cognitive decline. When a resident is not allowed to enjoy their typical routine, interact with their friends, have a change in scenery, or participate in music or social programs, this reduces mental stimulation and places residents at risk for cognitive loss. It causes emotional and psychological distress and decline, including apathy, depression, anxiety, reduced connection with reality, discouragement, and residents who just want to give up. And these are not temporary declines, and this is not theoretical in nature. Recently, we had several residents who contracted COVID. When told they had to remain in their room for 10 days, I heard statements such as, "I'm not even sick. Why do I have to stay in my room? I'm going crazy. I need to get out. How is it possible that I have to be in here for 10 days? Not again. This feels like I'm in jail." One resident was so upset, she hit the wall repeatedly with her hand and was inconsolable as she cried. And upon getting out of isolation, another came into my office saying, "I'm free. I'm finally free." As healthcare providers, we are required to do no harm, to weigh the risks versus benefits, and to provide holistic care in a home-like environment. No one else in the United States is required to isolate for a minimum of 10 days. I love and serve my residents, and it's my honor to magnify their voices. It is past time to decrease the isolation requirement so we can provide ethical and medically appropriate care to the people who for so many years have served and cared for us. Thank you.
Thank you, Esther, for your comment. We can move on to our next commenter.
Brittany Davis.
Hi, I just wanted to thank everybody for letting me speak today. So I just wanted to say I'm a dentist in the state of Georgia. I wanted to provide a little bit of perspective from the healthcare provider aspect of things. So I finished my training as a dentist at Columbia University College of Dental Medicine, and I was a student between the years of 2019 and 2021 when the COVID-19 outbreak first became introduced to the US, essentially. And so if we all remember New York being one of the first states that was hit incredibly hard by this pandemic. And then also working in a dental clinic, we were determined to be one of the highest risk spaces in the hospital for several reasons. As dentists, using drills and other tools, we are generating aerosols within a patient's mouth. Of course, we are in very close proximity to our patients, face to face within just a few feet. And we are in close proximity for an extended period of time, upwards of potentially 2 or 3 hours, given a particularly long treatment plan. And so during this time, our school initiated mandatory N95 respirators, PPE, routine COVID testing of both ourselves as student providers and of patients. It was a very rigorous sort of precaution protocol, and it was highly effective. During those years, we had no documented cases of any COVID spread between or from us as student providers to our patients, or vice versa, from a patient to students. And so having this mandatory N95 respirator mandate, so it kept us as providers safe. It kept patients safe. If a student were to be asymptomatic and have COVID, fortunately, we are minimizing the risk of spreading it to, upwards of hundreds of patients over, an extended period of time. It's also keeping safe our clinic staff and our maintenance personnel. All people who are just really essential to running a clinic effectively. And so ultimately, I just want to say I'm in favor for increasing universal precautions, including N95 respirator wear in healthcare establishments, just for all of our safety, essentially. Thank you.
Thank you for your comment, Brittany. We can move on to our next commenter.
Lisa Foreman. Lisa, can you please come off mute?
Okay, thank you. My name is Lisa Foreman. I'm a nurse practitioner with over 20 years of clinical experience and no conflicts of interest. I want to address the need for continuous universal respirator use in healthcare. We know that COVID-19 and many other pathogens are primarily airborne, and that breathing is an aerosol generating procedure. 5 years into this pandemic, the risk is no longer limited to the acute phase. COVID affects every organ and system of the body. It is not primarily a respiratory infection, but an airborne vasculitis. Therefore, it shouldn't be categorized with most other common respiratory pathogens. With repeated infections, an increasing percent of the population will develop long COVID. Early on, we heard the claim that COVID would be a mass disabling event. Unfortunately, the data shows that this is precisely what is happening. Currently, we're facing the very real prospect of an additional pandemic with avian influenza and likely others within our lifetimes. Minimum standard PPE in healthcare should be the N95. We don't need RCTs to evaluate their efficacy because respirators rely on principles of engineering and physics. Surgical masks work for splashes, but they otherwise offer very little protection to the patient or the worker. I have directly measured this in my own home with a port-account fit testing machine, and my results were typical. The air inside a surgical mask contains about half the number of particles as the air outside the mask. Compare this to a well-fitted N95 with at least 100 times fewer particles inside. Even a non-fit tested respirator provides overall better protection due to the quality of the filter. There is simply no comparison. We know that over half of COVID infections are asymptomatic and that many healthcare workers go to work while actively infected. COVID infections are not seasonal, so respirators in healthcare shouldn't be either. Limiting respirator use to voluntary policies and local transmission metrics has mainly one outcome. It avoids overloading hospitals. But the world's reality now is that surgical masks and bare faces indoors with others are not safe, especially in healthcare facilities. Many people have put off all non-emergency healthcare for years because they can't safely access it. And there's an imbalance of power that makes self-advocacy difficult. Often, when patients ask their healthcare workers to mask, they are told, CDC says we don't have to. And the ADA accommodations are often ineffective. Patients depend on us to protect them, and we are morally obligated to do that. We should not be giving them one disease while treating them for another. It is wrong to ask patients to assume a 10% mortality risk from a hospital-acquired COVID infection. We can't ignore what they need because it's uncomfortable or expensive. We know what should be done, and it's doable. My spouse and I are healthcare providers, and we do it every day. Please give our patients the safer healthcare they need. Thank you.
Thank you, Lisa, for your comment. We can move on to our last commenter.
Barry Hunt.
Thank you. I have no conflicts. This is a turning point in the history of disease transmission and infection control. We already face an unprecedented challenge of pathogens that transmit through the air with even more serious, highly pathogenic threats on the horizon. The need for engineered infection prevention and universal air precautions is becoming more imperative by the day. Today, there's a teenager in critical condition in ICU, Canada's first known case of the highly pathogenic strain of H5N1. It won't be the last. Here's what's happening in Canadian standards. Because respirators are too hard to breathe through, Canada created the world's first new easy breathing category, less than 100 pascals, significantly easier breathing than the NIOSH standard of 245 pascals. National standards now in development include universal respirator use in healthcare, PAPRs for RG4 pathogens, bioaerosol respirators with breathing resistance as low as 25 pascals, and engineered infection prevention technologies like auto UV, far UV, and upper air UV. My recommendations to this committee, 1, specify easy breathing N95s, less than 100 pascals. 2, encourage NIOSH to create a bioaerosol respirator standard with breathing resistance as low as 25 pascals. 3, specify and encourage adoption of engineered infection prevention, including engineered air protection rooms, a minimum of 6 air changes per hour from ventilation, and the equivalent of 30 additional air changes per hour from upper air UV, far UV, air purifiers, or displacement ventilation. 4, specify new precautions categories. 1, universal air precautions, respirators. 2, engineered air precautions, so respirators plus engineering controls for RG3s. And 3, isolation air precautions, so PAPRs, engineering controls, and airborne isolation rooms for RG4s. Over the past 10 years, it's quite possible that engineered infection prevention plus universal air precautions could have prevented some 10 to 20 million hospital-acquired infections, up to 1 million deaths, and saved $1 trillion or so.
All right, you're almost ready?
Disease transmission in hospital continues to get worse, not better. It used to be that 5% of infections were acquired in hospital. Now it can be 10 to 20% for some diseases. It used to be HIR mortality was 5%. Now it can be 10% or even higher for some diseases. The one-time capital cost to deploy engineered infection prevention across 1 million beds in the US and Canada together would be about $50 billion. The net return, though, could be $50 billion per year, every year, a smart investment that could pay dividends for years to come. Every journey begins with a first step. Let's take that first step now by recommending engineered infection prevention and universal airborne precautions. Thanks.
Thank you, Barry, for your comment. We appreciate it, and I would like to thank all those who had the opportunity to have a comment during the oral comment period, public comment period, and those who have submitted written comments as well. I'm going to hand it over to our chair, Michael Lynn.
Thank you, Sydney, and again, thank you to everybody who contributed to the public comment period. I'll now go ahead and summarize the meeting for today. Today we welcomed 1 new HICPAC member, Leela Looper, and 3 new ex officio members, Scott Copper, Shavana White, and Kristen Dillon. We heard updates from the CDC's Division of Healthcare Quality Promotion regarding activities related to broadening the scope of DHQP to include rural health expertise, long-term care, pediatrics, in maternal care, dialysis centers and home dialysis, and outpatient areas. We heard about technologies such as cleaning and disinfection sterilization related to environmental cleaning and the need to communicate these types of new technologies to frontline personnel through better education. I also heard a little bit about AI technology and its potential impact on infection prevention. And lastly, heard about integrated healthcare system approaches for surveillance and data sharing, how to integrate these types of approaches into a functional whole that is both comprehensive and resilient. We had a discussion regarding 4 CDC questions posed to CDC regarding updates to the isolation precautions guideline. The discussion was led by Sharon Wright and myself. The 4 CDC questions touched on topics related to control of pathogens that transmit by air, including the role of masks for infection prevention, clarification of approaches to application of transmission-based precautions, voluntary use of respirators, and the use of mask source control in healthcare facilities. The discussion will continue at tomorrow's session with a vote anticipated to provide responses from HICPAC back to CDC. I want to emphasize that the vote will be regarding the HICPAC responses to the 4 CDC questions to provide direction to the draft guideline development, and the vote will not be on any specific language contained in the draft guideline itself or any of its recommendations. Today, we also had a discussion regarding recommendations for healthcare personnel guideline, chaired by Connie Steed and with input from DFO David Kuhar. We heard a presentation regarding the rationale, considerations, evidence, and proposed draft recommendations pertaining to work restrictions for healthcare personnel in 2 scenarios: asymptomatic healthcare personnel who have had an exposure to influenza or SARS-CoV-2 infection, and to patients or people with SARS-CoV-2 infection or influenza. And number 2, healthcare personnel who are not moderately or too severely immunocompromised with mild to moderate suspected or confirmed influenza or SARS-CoV-2 infections. The discussion and feedback heard today will inform a vote for tomorrow on these healthcare personnel work restriction recommendations. And we had a public comment period during this meeting, and we appreciate the oral comments raised. We also have received written comments submitted to the committee. I want to sincerely thank HICPAC members, ex officios, liaisons, CDC staff, and the general public for your attendance today. The committee will reconvene tomorrow at 8 a.m. Eastern Time. Thank you.